to thank Corona Remedies for giving me this opportunity. Today, I'll be talking about hypertension and vascular disease in DKD progression, the vascular crossroad. Next slide. So, as we all know, that previously it was considered that diabetic kidney disease is has a single uniform trajectory. All the patients with diabetes and DKD will behave similarly. So because of this, it was considered that it's a uniform single disease. The Renal Pathological Society has classified diabetic kidney disease into various type of diseases. Like it has had glomerular basement membrane thickening. Mesangial expansion is found on kidney biopsy, nodular glomerular sclerosis, typically known as KW lesions, and global glomerular sclerosis. But with recent growing consensus, it has been found that various different pathophysiological pathways are there in patients with diabetes who develop CKD. So it is not a uniform disease. It has various subgroups. And better characterization and mechanical understanding of these subgroups offers us to have a different diagnostic and have improved prognostics for these patients. Next slide. So going on to the perspective of kidney disease, historically kidney disease was classified as AKI and CKD. A new term which is known as AKD has been introduced. All these are on the basis of the time duration. So any kidney injury which is less than 7 days of duration is known as AKI. Anything between 7 days to 3 months is AKD, and beyond 3 months we call as CKD. So AKI is an acute injury to the kidney. It can lead on to a complete recovery from the disease or can cause the death of the patient. The third thing is that it can go on to AKD. So any AKI going beyond 7 days is AKD. Any AKD going beyond 3 months is CKD. Next slide. So again, a summary of these kidney disease parameters. It's very important to understand this to later on understand the diabetic kidney disease. So AKI can be defined as an increase in serum creatinine by 50% within 7 days, or an absolute increase of serum creatinine by 0.3 milligram per deciliter on an oliguria of more than 6 hours, occurring for less than 7 days. That is AKI. Anything between 7 days to 3 months is CKD. AKI, which can be defined as an eGFR of less than 60 for a duration of less than 3 months, or a decrease in GFR by more than 35%, or an absolute increase in serum creatinine by 50%, occurring for less than 3 months. Anything which is with a GFR of less than 60 for more than 3 months is CKD. Next slide. So this is basically a slide which is showing the prevalence of CKD in patients who are diabetic. So if we go on to the global data, it has been approximated that half of all the patients with diabetes, they eventually develop CKD, which is normally presumed as because of the diabetic kidney disease. If you see the definition of CKD, it has two parameters, an eGFR of less than 60 or a albuminuria, presence of albuminuria. According to the global data, about 50% of patients of diabetic develop CKD. When we see the data from different countries, it has been seen that in the US, about 27% of patients are albuminuric, 9% of patients have a eGFR of less than 60, whereas 10% have features of both. Going on to the Australian data, they have more number of patients, diabetics, who develop albuminuria. Similar data is found in in the demand study, which was done in the Asian population, where around 40% of the patients with diabetes eventually developed albuminuria going on to CKD, whereas only 6% of patients developed the eGFR with less of albuminuria. So patients of Asian origin, they are more albuminuric, what we can see from this study. Next slide. So why is it important to identify diabetic kidney disease or CKD in diabetes? Because it has been forecasted that the CKD and diabetic kidney disease would be a leading cause of death by 2040. When we compare the data from the cause of death or all-cause mortality in 2016, it has been seen that CKD is lower down, diabetes is lower down. Whereas the projections say that CKD, Alzheimer's and diabetes would be the leading cause of death by 2040. There has been forecasted that around 160% increase of death because of CKD would occur in 2040. So it is very important to diagnose it early, to catch them, to know the pathophysiology and to treat them. Next slide. So when we say that CKD in diabetes is not a uniform disease, so that means there are various factors which lead on to the progression of renal disease in diabetic patient. So these risk factors for the development of renal disease can be classified as modifiable or non-modifiable. Non-modifiable would be an increasing age and early age of onset of diabetes, a prolonged duration of diabetes, genetic factor. People who have history of CKD in the family, they're more prone to develop CKD themselves. ethnicity. Like we have seen from the previous slide, Asians and Australians and Blacks, they are more prone to develop early kidney disease as compared to the Caucasian population. Patients who are born as an intrauterine growth retardation, patients who were born with less birth weight, or who themselves were IUGR babies, they have less number of nephrons in the kidney, so they tend to develop CKD early. So, and the other important factor is maternal gestational diabetes. So, children who are born as a birth from when their mothers develop gestational diabetes, they tend to develop renal dysfunction more as compared to people who were born with normal pregnancies. So these were the non-modifiable risk factors. The modifiable risk factors would include, again, very important, poor glycemic controls, hypertension. Now, hypertension is another important factor for development of or progression of renal disease in diabetic patient. Dyslipidemia, patients who have a poor or a lower socioeconomic strata, patients who have a sedentary lifestyle, who are obese, who are smokers, who have insulin resistance or other chronic infections. And again, the patients who have recurrent episodes of acute kidney injury, they tend to develop CKD more as compared to patients who have not had episodes of acute kidney injury. Then oral contraceptive use in females are another predisposing factors for development of renal failure, hyperuricemia, and vitamin D deficiency. Out of all of these, hypertension is the most important risk factor for development of CKD in both type 1 and type 2 diabetes. Why is this important? Is because in diabetics, they lose the renal autoregulation. In normal patients, normal people, there's a renal autoregulation. So even when the BP is high, this blood pressure, systemic blood pressure is high, this blood pressure is not transmitted to the kidney. But in patients who are diabetic, they lose this renal autoregulation. So any rise in blood pressure, it's directly transmitted to the kidney and causes damage to the glomerular capillaries, leading again on to the more of fibrosis and more of progression of renal failure. Next slide. So this is a graphic representation of the glomerulus. What we can see here is if the patient has high glomerular blood glucose level, this blood glucose is filtered at the glomerulus capillaries. The glucose itself and the glycation end products, they are toxic to the endothelium, leading on to endothelial cell apoptosis. All of these causes more of inflammation, leading on to the mesangium. Mesangium is the intracellular matrix between the glomerular capillaries. So this mesangial cells, they hypertrophy, there is increase in the mesangial matrix. There is apoptosis of the podocytes, which are the cells which are present in the glomerulus. So all of these causes more of glomerulosclerosis. It causes more of injury to the glomerulus. Now, this filtered glucose is again, passes through the renal tubules, causing to the cell, causing the problems and injury to the renal epithelial cells, causing fibrosis and apoptosis of the renal epithelial cells. All these glomerular injury and the tubular injury leads on to progression and fibrosis of the glomerulus, leading on to progression of renal failure. Next slide. So what was presented at the ADA this time was a Berry triple biopsy study in DKD and the results from the IBEAT DKD study. Next slide. This basically was a protocol research biopsy-based study, which was done to identify the phenotype of CKD in diabetic patient. So the CKD in diabetic was classified as diabetic kidney disease, non-diabetic kidney disease, and a combination of both. Next slide. What they did in this study was they collected all the demographic data. The age was collected, the diabetes duration was collected, the glucose, the blood sugar control was the data was collected in the form of blood glucose levels, HbA1c. Obesity was catered to by collecting data on BMI, glycated albumin was collected. Renal parameters, the data were collected by urea, creatinine, EGFR. They collected the data on urinary albumin by creatinine ratio. Serum protein and albumin was collected. Various parameters of blood pressure in the form of diastolic blood pressure and systolic blood pressure was collected. And the cholesterol parameters was collected. It was basically a 4-year study, and every year follow-up was done. On the basis, the patients who, out of these patients, about 96 patients underwent a kidney biopsy, and various parameter data were collected on the basis of kidney biopsy, which included histopathology, which included IF and electron microscopy. Next slide. So the results from the Berry study was they found that around 256 patients were total stratified in the Berry cohort, and they were classified on the basis of EGFR as G1 to G5, G1 being a EGFR of more than 90, G2 GFR between 60 to 90, G3A was a GFR between 45 to 50. G3B was 30 to 45. G4 was 15 to 30. And G5 was less than 50 or end-stage renal disease. The other way it was classified was on the basis of albuminuria A1, A2, and A3. A1 being normal albuminuria with less than albuminuria of less than 30. A2 was moderately increased albuminuria in the form of album ACR between 30 to 300, and A3 was albuminuria of more than 300, which was severely increased albuminuria. The patients who were included in this study were around 45% were patients who were G2, that is the stage 2 of CKD, and around another to say 18% were around with class 3. So around what we can say 60% or two-thirds of the patients in this were patients who were class 2 or class 3 of CKD already. Now the out of these patients who were included, around 96 underwent a protocol kidney biopsy. The patients who underwent a kidney biopsy were those, especially those 80% of patients were those who already had albuminuria, either moderately increased or severely increased albuminuria. So next slide. So what we have known from the previous slide is patients who were included in the study were already those who had a class 2 or class 3 CKD on the basis of EGFR and were albuminuria. Now, the subgroup analysis, the patients, according to the biopsy, they were classified as patients who had vascular reason for the renal failure. That is shown in the blue bar. The red bar includes those which have both metabolic and vascular lesions. So, out of the total 96 biopsy, 35.4% were patients who had vascular lesions. These were the patients who did not, who were diabetic, had CKD, but diabetic kidney disease was not the cause of renal failure in these patients. This included a major majority, 35.4. Around 25% were those who had both vascular as well as diabetic kidney disease as the cause of renal failure. The others included immunological vascular as well as mixed. If we go on to the subgroup analysis on the basis of albuminuria, about 87% of the patients who were non-albuminuric, patients who were diabetic, had CKD but non-albuminuric, 87% of those were found on the basis of biopsy were found to have non-diabetic kidney disease. So this is a major proportion. So patients who are diabetic, who have CKD, but who are not albuminuric, in those patients, a reason other than diabetic kidney disease is the cause of CKD. As the albuminuria increased, in patients who were A2, that is, had an albuminuria between 30 to 300 milligram, around 47% were vascular. Half of the patients here also were those who did not have diabetic kidney disease. Other causes or hypertension was the major cause of renal failure in this patient. A3 was definitely more of diabetic kidney disease. Next slide. A similar study was done by Mazzucco. In this study, basically 390 patients were included in this study. And it has Mazzucco study have classified diabetes, renal failure on the basis of biopsy as class 1, which is diabetic glomerular sclerosis, class 2, which is vascular in the form of ischemic glomerular or arteriosclerosis. Class 3A is those who have glomerular disease superimposed on diabetic kidney disease, and 3B were those who had other glomerular diseases. Next slide. Going on to this data from the Mazzucco classification, what they found was about 35% of patients, again, here had vascular. All of the 390, out of the 390 biopsies, 35% of them had non-diabetic disease as the cause of CKD. 33% were those who had diabetic kidney disease as well as non-diabetic kidney disease. Whereas 23%, one-fourth of the patient had other immunological diseases as the cause of renal failure, even in diabetics. Going on to the Berry classification, similar data is seen about 35% of patients with diabetes, CKD. The reason for the CKD was non-diabetic. Next slide. Again, this is basically comparing Mazzucco and the Berry classification. Out of the 96 patients in the Berry group, about the DKD, that is the diabetes as the cause of kidney failure, 9% had pure metabolic or pure diabetic kidney disease, 24% had both metabolic as well as vascular. Non-diabetic kidney disease was found in 60% of patients, and the combination was found in 8% of both. So both these studies basically tell us that even in patients who are diabetic, who have kidney disease, we should not be taking it on face value as this will be diabetic kidney disease. We have to look for other factors. We have to look for other causes of renal failure in these patients. Next slide. So the second thing which was presented in ADA was Kidney Precision Medicine Project. Next slide. So this is basically a multi-year collaboration of various research institutions in which was done to study various mechanisms of AKI and CKD. Patients, the goal of these KPMP was to collaborate with various research institutions and to find out and evaluate kidney biopsies from various patients who have AKI, CKD, or other diseases. We define the second goal was to define the disease subgroup. Then we have to identify the various pathways and target the various newer therapies and create a kidney tissue atlas. Next slide. So the patients who were included were diabetic kidney disease, both type 1, type 2, hypertension, and patients who presented with AKI. Excluding were pediatric people with less than 18 years of age, or patients who had glomerular diseases, kidney transplantation, and malignancy and pregnancy. These were the patients who were excluded from this. The patients in this project, clinical presentation of clinical data was collected. The traditional and digital pathology, including EM, was done. Various transcriptomics was run on these kidney biopsies, and we have to study this. What they studied was kidney disease progression, kidney failure, AKI, and hospitalization. The main aim was to create a reference kidney tissue cells to understand the various mechanism of the disease, to identify the targets which can be used for newer therapies. Next slide. So this is from a KPMP study. This is basically a patient with the past stain of the kidney biopsy from a diabetic patient. What we can see on the right-hand side group is this is a high power view of the glomerulus. The mesangial matrix is increased, which is in the form of deep pink color. And the arteriole, which we can see here, is also deep pink because of the arteriosclerosis. This is a mixed lesion of patient with diabetes. Next slide. So what is the impact of this? Why do we want to do a KPMP? This is because we have to identify all the patients with diabetes, all the patients with the hypertension are not diabetic kidney disease. We have to identify the various causes so that patients can be treated properly. Like if we see on the entry cohort, around 57 patients were initially labeled as diabetic kidney disease. Out of this, 42 only turned out to be diabetic kidney disease. Around 13% of patients were hypertensive kidney disease. And another 5% of patients, the cause were not identified, whereas 4% of patients actually had immunological disease of the kidney, where proper and different treatment can lead on to improvement of the disease. Next slide. So in conclusion, what I can want to say is we have to, in all the patients who are diabetic, who have CKD, we have to look out for other causes in addition to diabetic kidney disease. So a comprehensive phenotyping and biomarker discovery is important. We have to refine our disease classification so that we can treat the patients properly. A systemic biological approach to identify newer biomarkers to differentiate between diabetic kidney disease, hypertensive kidney disease, and other causes of kidney disease is required. And a precision medicine framework is needed to identify new biomarkers so that patients can be treated properly. Thank you.